So, good evening, everyone. I'm Dr. Kshitija Patil, consultant clinical geneticist at Apollo Hospitals, Navi, Mumbai. I completed my DM in medical genetics from AIMS, New Delhi, and my clinical work focuses on diagnosis and management of patients with rare genetic disorders. On behalf of Organization of Rare Diseases India, ORDI, I would like to extend a very warm welcome to all of you joining us today for yet another session of ORDI Rare Info series. ORDI has been playing an important role in India by creating a platform where clinicians, researchers, patients, caregivers, and advocacy groups can come together to discuss rare diseases. These conversations are essential not only for improving medical awareness, but also for strengthening the patient support networks and advancing access to care. Before we begin, I would like to inform everyone that today's webinar is being recorded and the recording will be made available later on the ORDI YouTube channel. For those who would like to revisit the session or share with their colleagues, they can visit the YouTube channel. So today's topic is going to be about Huntington disease, a progressive neurodegenerative disorder that classically presents with a triad of movement abnormalities, cognitive decline, and psychiatric symptoms. What makes this disease particularly challenging is not just the clinical progression of the disorder, but also the complex issues surrounding the predictive genetic testing, family counseling, and long-term care for the affected families. At the same time, this field is witnessing significant scientific advances, especially with the development of the gene-targeted therapies aimed at lowering the mutant Huntington protein. While many of these approaches are still under investigation, they represent an important step towards disease-modifying treatments. Given these evolving developments, discussions around Huntington disease today extend far beyond diagnosis, and that is exactly what we are hoping to explore in today's session. To guide us through this important issue, we are honored to have with us Dr. Mitesh Shetty. Dr. Shetty is the head of department and senior consultant in medical genetics at Manipal Hospital, Bangalore. He is also a certified clinical laboratory geneticist by European Board of Medical Genetics. In addition to his clinical work, Dr. Shetty is deeply involved in genetics education and training. He serves as the course director and adjunct faculty for the MSc program in genomic counseling and fellowship in molecular genetic pathology offered by Manipal Academy of Higher Education. He is also a professor of practice in cell biology and molecular genetics at Sri Devraj Academy of Higher Education, Kolar. With more than 2 decades of experience in clinical genetics, Dr. Shetty has extensive expertise in prenatal diagnosis, genetic counseling, cytogenetics, phage, biochemical screening, molecular genetic technologies like CMA, NGS, Sanger sequencing. We're truly privileged to have him with us today to share his insights on the clinical and genetic challenges surrounding Huntington disease. Dr. Shetty, thank you so much for joining us today. Before we proceed, a quick note for the audience that if you have any questions related to the talk, please feel free to type them in the chat box below, and we can take them up in the Q&A session at the end. Over to you, sir.
Thank you, Dr. Kshitija, and thank you, ORDI, for giving this opportunity. So I'll start sharing my...
Right.
So today's topic is about the challenges in the Huntington disease. So okay, so I'm going to talk about Huntington disease. So people, to understand Huntington disease, as Dr. Kshitija already told, it is very challenging in understanding Huntington disease. So what is Huntington disease? Huntington disease is a adult onset neurodegenerative disorder. It is autosomal dominant inheritance, and it is late age onset disorder. So usually the conditions start late 30s and 40s. And the incidence...
Sorry to interrupt, sir. Sir, your slides are not in the full screen mode.
It is in full screen.
I mean, it's not in that slideshow mode, sir.
Okay, 1 second. You are able to see?
Yeah, the slides are visible, sir, but they are not in the slideshow mode.
Is
Yeah.
it there? It's correct, right?
Yes, yes.
Okay. So, so usually it is 15 to 20 years duration. The clinical triad of the Huntington disease, it is motor, cognitive, and psychiatric. Now, this was first described by George Huntington in 1872, and the condition showed adult onset and progressive chorea. So he also noted that there is a behavioral and cognitive changes. Now, it was first published in 1873 on chorea and a medical and surgical reporter. The observation were based on the families he had seen in the Long Island. So to understand this, so in this article he described that adult onset symptom, progressive coliform movement, mental deterioration, high suicidal tendency, and strong hereditary transmission. Now, why Huntington is important? So it is a progressive and fatal neurodegenerative disorder. There is currently no curative treatment. Now, something which has come up, as Dr. Kshitija just mentioned, that now there is some early signs of treatment for the Huntington is there, but it is still very early stage. And it affects the movement, cognition, and behavior. And it often affects the individual in productive adult years. It has a major psychological and social impact on the families. Is that good? Okay, so the incidence of Huntington worldwide is very high. It keeps varying, but in India also it is very common. So this is what we used to feel early, that Huntington disease is not there in India. But this is some of the condition when we started early in my practice, like for 20, 22 years back. This was one of the common thing which we used to get a reference. Maybe one of the probably reason is that we being in the Bangalore, the NIMHANS is here, so we used to get lot of this Huntington cases which is coming from different parts of the country. So in India also, the incidence is 1.35 per 1 lakh population. Now, as we explained, like now there is a cognition involved and there is a neuropsychiatric and motor. So there is a deficit in executive function, impaired visual, facial ability, memory loss, anxiety, irritability, chorea, dystonia. All these features are there in the Huntington. So before that, So I just want to show this video. It's a very short video about how is the Huntington disease looks like. You are able to see the video?
No, doctor.
Okay, I think there is a challenge. Is it visible now?
Yes, sir. Yes, sir.
Okay, if you would count backwards from 100 by 3.
Okay, so if you see this patient, how they are continuously moving and their uncontrolled behavior. So, and they will, when they're sitting in front of you, they'll be continuously fidgeting. So they can't sit, and when they're walking, it will be like drunkard walking, and all these features, they will keep increasing. And as I told you, like it starts late. Is it visible now, the PPT?
No, we are still seeing the video, sir. The video is paused.
The challenges. This one. Is it PPT visible now?
Yes, sir. PPT has come.
Okay.
Yes,
this
now
is
it's in the screen.
important thing which I wanted to, because people usually they don't understand what is Huntington. Unless you see the patient with the Huntington, then you will realize what are the challenges are there in the Huntington. The challenge in the Huntington, just describing that it is neurodegenerative changes, it starts late. But when you see that all these changes which is there and which is going to increase, then that becomes very challenging for the family members. So how to they know that they may be at risk of developing this condition. So that's the reason I feel the Huntington is very challenging for counseling. Practically, when you see Huntington patient who is having this problem, it is the challenges in the counseling the other family members. So that is you have to understand the person who is affected, for him it is like no, not that much impacting and all those things, but the family members, it is very difficult to counsel them. So the early symptoms can be like no slight uncontrollable muscular movement, stumbling and clumsiness, lack of concentration, short-term memory lapse, depression, changes of mood. So mood swing is another thing which is very common in the Huntington. So the disease, as I told you, like it's late onset, but it keeps progressing. So the motor milestone, starting from the 40 age, the progression of the motor milestone, cognitive in Korea, all this thing will increase with the age. Now the age of onset will be around 30, late 30s to average, but then it will keep varying from the family, depending upon the family history and the repeat number, which is again very important to understand, correlate clinically, but in practical scenario, I have not seen anything like that. So how it discovered that no, the gene is expressed location was found in 1983, but early days it was only till 1993 the gene was not found, and the worldwide collaboration scientists they finally localized the gene to chromosome 4p, and the gene was identified as HTT gene. And in 1993 it was first described, and it is different. As I told you, it is the mutation, it is not a regular mutation. There is expansion of the amino acid trinucleotide repeat disorder. So CAG code of amino acid glutamate. So this expansion in the abnormal Huntington protein, and abnormal protein production causes this neurodegeneration. Now this is a CAG repeat. Now understanding CAG repeat is very challenging, and normally the person should have less than 27 repeat, and 27 to 35, like no, they will not have any symptoms, and but most likely they'll be carrier or intermediate risk. Individual with the HD may have 36 or more repeats. So it is usually in last 20 years, more than that. What I've seen, it is around 42 repeats only. I've not seen anything which is more than that. And but earlier days we never used to get the repeat number, so we used to just get HD positive or negative. So now after we are able to quantify this repeat number, but it is coming around that 40 to 43 only, and in that report also you will be plus or minus 1 or 2 repeats. So it is very narrow range of this repeat which is giving this problem. So this is what the HTT gene located on a chromosome 4 contains a stutter of CAG trinucleotide. Genetic anticipation number of repeats often increases when passed down, particularly to the paternal side. The paternal lineage may there is a CAG the repeat can jump, so that it can become, the onset can become early or very severe. The somatic instability, the CAG tract contains continue to expand within the specific brain cell throughout an individual's life, accelerating the disease. Now, how does it happens at the molecular level or the protein level? What happens? So toxic gain of function. The CAG sequence translate into amino acid glutamine. The expanded gene creates an abnormally long polyQ chain in the HTT protein. This extra long chain causes the HTT protein to lose its normal shape and fold incorrectly. And this enzyme cuts the misfolded protein into smaller, highly toxic and terminal fragments. These fragments clump together to form aggregates in the cell's nucleus and cytoplasm, disrupting the normal cellular function. And so this is what happens. There is a normal CAG repeats, there is healthy neuron, and there is a repeat expansion happens, the CAG expansion, and there is aggregation, and there is a neuronal degeneration. So diagnosing Huntington disease. So how do we diagnose? So primarily, beside complete physical examination, initial evaluation usually includes comprehensive family medical history and neurological examination, and then you move to a laboratory test, brain imaging, and then end genetic testing. Cognitive dysfunction may occur prior to motor symptoms in some individuals with Huntington disease. So current diagnostic criteria for Huntington disease. In 2019, the Movement Disorder Society proposed 3 diagnostic criteria: pre-symptomatic Huntington, prodromal, and manifesting Huntington. The cognitive and motor criteria for each of these 3 categories were developed using a consensus approach. These 3 diagnostic criteria of HD should be reflect the clinical status of patient with HD as opposed to the genetic, diagnostic, or biomarker test result. So diagnosing manifesting HD results in functional disability with a significant decline in social and occupational function, difficulty in performing basic activity of daily living. The diagnostic criteria for manifesting HD consist of the following: the motor symptom resulting in a diagnostic confidence range of 3 accompanied by minor or major neurocognitive changes. Motor symptoms include in a diagnostic confidence rank of 4 with the normal cognition. So first will be the cognitive criteria. This is based on the Diagnostic and Statistical Manual of Mental Disorder (DSM) category, and then there is a motor criteria which can need to consider into different ranges from 0 to 124. So there are different stages. So it is very, I have not seen anything very early, only the family when you see. Otherwise, when you see most of the time Huntington, they are always in manifesting. So you can, it's very difficult. You can make out the confirm the diagnosis itself when you see the patient. So the manifestation, it's the clinical history is so clear that you can make out that it is Huntington. And then the diagnostic criteria of testing and other parameters just helps us in categorizing it further and primarily confirming the diagnosis in the family. So the Huntington disease, you see the number of, there are different stages and what happens with the biomarker and clinical signs and then the functional changes. So with all these things, the MRI findings and the clinical findings and the family history will definitely give you a lot of information. This is some of the one of the very few genetic condition where you can learn whatever you read in the family pedigree. You can see all those things when you are drawing those family pedigree. You will see classical signs of autosomal dominant inheritance with multiple people affected in the family. So this is one of the rare thing which you can see how autosomal dominant inheritance can spread in a family. So you will see all those. So here the family tree will give you a lot of information, like the age of onset, the severity, all those things need to be captured so that it will give you average age of onset in a family. So this is what is the average age of onset in the family. That will help us to some extent to tell some rough idea. Yeah, this is what the usual expectancy of this condition can be there. But it gets complicated when the repeat jump happens. So another thing, if you see the MRI finding is very typical for the Huntington disease. So there will be caudate head atrophy. So that is very classical sign of for the Huntington disease. Now there is another term which is called as juvenile Huntington. Now juvenile Huntington means anything which is starting before 20 is considered to be a juvenile Huntington. As I told, the Huntington is a late age onset. So usually it starts late 30s. Okay, not in 30s also, late 30s. So anything which is onset is less than 20, then it will be fitting into criteria of juvenile Huntington disease. So often leading to initial misdiagnosis. Now the another thing is autism and ADHD. The motor symptoms of the juvenile Huntington is unlike the classic chorea which is seen in the adult Huntington disease. And the key motor features will be rigidity, stiffness, bradykinesia, dystonia, and absence of chorea. So the chorea will not be the primary feature. And the rapid progression. As the name suggests, the juvenile Huntington, there it typically progresses twice as fast as the adult form with a shorter median survival. So the progression of this condition will be very fast, and usually there will be larger expansion. The CAG repeats number will be higher, usually more than 55 to 60, and more than 80 is strongly linked to childhood onset. The paternal inheritance, usually if there is a jump, juvenile Huntington is usually seen when it is coming from the father side. So there is a anticipation of the jump happens when it is coming from the father side. So father side, if there is a history, there is a possibility of the jump in the repeat number. So far I have not seen any juvenile Huntington, but yes, this is what the severity is very high. And apart from the features that there is no chorea, but there can be other features of seizures and the cognitive and the school decline, psychiatric severity, and unique sensory symptoms of chronic pain and itching and all those things. Now, diagnostic testing. Now, here comes little challenging. Challenges in the sense like where to do genetic testing and how to do genetic testing in Huntington. It is not a usual condition which you need to understand. So, diagnostic testing only once you have the manifesting Huntington disease to confirm the diagnosis. So once they confirm the diagnosis, that it is confirmed, and it is for the confirmation and other testing, not testing, it is helpful for other family members. Then comes the predictive testing. Again, it is very challenging. It should not be done. And then I'll talk about it a little bit later. So then prenatal testing and pre-implantation genetic testing. For doing this, we need to confirm the diagnosis and confirm the diagnosis at the repeat number. So for that, PND and PGT, we need the confirmation of diagnosis in the family. So the counseling is again, for any genetic condition, it is important to do a pre-test genetic counseling and what you are going to expect from the result. The important factor here would be the partner who is accompanying. You have to be very important, because they should always come with somebody who is there, and you make sure that the same partner, relative or this thing, they are present during the post-test counseling also. So this is very important, because you're talking to as I told you, most of the time these people they are they're not able to follow all those things. So it is the family member who need to be present and all those things. Very rarely, sometimes some early person also can come into it, but you should always insist upon they need to come with the somebody, some partner, friend, and all those things. So when they're coming for the report, so testing can be done with the proper counseling and all those things, but report need not be given alone to the patient. Now, prenatal diagnosis. Prenatal diagnosis, once we identify, we can definitely help it in preventing this condition. So once a kind diagnosis is confirmed, usually we offer a CVS. Now, CVS is done because you know the condition, you have identified the diagnosis, and then you can offer early diagnosis uh, at 12 weeks of gestation. So usually we do a non-disclosure testing. So that means we don't test the person or the asymptomatic, but the person we test in the family, the grandparents or the parents, and then test the fetus. So in this, you can avoid telling the patient about their status. Then this was we used to do earlier, this non-disclosure prenatal diagnosis, and but nowadays with the this IVF and pre-implantation genetic test, it has become very convenient. So that this is what we feel that this should be the first line for the Huntington for two reasons. One, it is autosomal dominant inheritance, so 50% is a higher risk. And the second would be because you will not identify the status of the parents. So it is very important. The PGT helps in hiding the status of the parent. So non-disclosure. So non-disclosure is that parent undergoes IVF, but they will not be knowing their status. So this is what you have to understand. And cascading testing. So usually whenever there is a genetic condition there, you always tell that no other affected family members or at-risk people and can be tested, but those things will not apply in the Huntington. You need to be very careful for testing at-risk people here. You need to counsel them to, they should understand that what is the important. So diagnosis of pre-symptomatic HD, patient who have already been tested for Huntington, often prompted by family history of condition and have a CAG expansion in the absence of sign and symptoms of HD, classifying having a pre-symptomatic Huntington. So they are having the features, but they are having the jump, but they are not having any features. Individuals with the pre-symptomatic HD do not present with the significant motor or cognitive sign. The criteria of pre-symptomatic consist of the following: absence of motor symptoms or presence of non-specific motor symptoms resulting in a diagnostic confidence ranking between 0 to 2, and normal cognition. Basically, they are asymptomatic and the diagnosis is confirmed in the family. So one of the parent has been tested and confirmed. So there is another, but pre-symptomatic testing usually we don't do. We need to talk to them that at least 2 to 3 sessions, that they should understand there is no advantage of identifying the condition, because we need to tell them that they need only if they are at risk, they should plan their financial planning and their health insurance planning. And if we can help them definitely if they are planning for pregnancy by preventing it by PGT or prenatal diagnosis. Apart from this 2-3 points, there is no benefit of testing the patient for pre-symptomatic. Similarly, there is another diagnosis for prodromal. This is something in between with the minor MRI changes and minor motor symptoms. So this is another prodromal stages where you can have minor changes in the brain finding. So testing in minors, obviously, it is not recommended because it will take it is, as I told you, testing for asymptomatic itself is not beneficial. So minor doesn't come into picture, and because of the regular reason, what we do for any other genetic practice, that it will take out the autonomy, self-determination, the right of to know the open future, absence of medical benefit, vulnerable child syndrome. The only rare scenario if the jump is very high and then you can suspect something of juvenile. I don't think any other reason minors should not be tested. Now, as I told you, counseling is very important, because there are so many different psychological aspects are there in the Huntington. So there is one survivor guilt is there in the context of Huntington disease is profound psychological phenomena where an individual who tests negative does not have the mutation feels intense shame, sadness or isolation because of their sibling or parents are affected. So you have to understand, like, no, when you have a parent, when you the diagnosis is done in the family, and you are seeing that one of the parent who is affected and the condition is deteriorating, and you know that you are at 50% risk of getting that condition. So suddenly you see that no that after proper counseling and multiple session, if they decide to test, then they feel that no, why only the other siblings are having it, they are not having it. Sometimes they are in the trauma that they will get this life, suddenly they are not able to accept the normal life also. So there are a lot of psychological issues in the Huntington. So Huntington pre-symptomatic and all those things. So why me only, he is not affected, betrayal of the family bond, anticipatory grief, all this thing will pop up in the patient who is negative. Impact on the family dynamic, sibling discordance, parental relationship, and overachiever response, isolation. These are all the things which can pop into the siblings when they see that, no, that one is affected, another is not affected. So the psychological problem is very, very different. People suddenly they realize, sometimes that's the reason pre-symptomatic and others are not encouraged, because when they see that if they are going to get this condition there and then they are going to deteriorate, so they are not able to cope up that thing, and people have committed suicide because of all this change of lifestyle life thing, in the sense that they will get this condition and they don't want to go to that level, so they commit suicide, even though that condition will come after 10 years or 15 years, and that 10 to 15 years of asymptomatic period, they will be continuously thinking about this condition and they will not be able to enjoy life. That's the reason the pre-symptomatic is not at all recommended. And as I told you, few points that, they need to have their health insurance in, keep it ready, arrange it according to their requirement, and then the financial planning. And whenever they are planning for any, if at all, depending upon they are planning for family expansion, that can be helpful. So genetic counseling, as I told you, is very important because of that so many psychological issues involved in this condition. So you take detailed history, you can learn a lot from this, as I explained to you. You will see typical autosomal dominant, you will see that you need to understand the age of onset and the severity. All this thing you can predict when you take a detailed family history. It will help you in understanding the roughly the age of onset. So inheritance, it is autosomal dominant 50%, and there is a paternal anticipation is there. Anticipation is nothing but there is an increase in the severity or early age of onset. So that is how the anticipation happens. And I 50% risk, and this is what, if you take the family tree, you'll see this classical autosomal dominant inheritance, where each generation there is a people who are affected with the Huntington condition. Counseling at risk adult, as I already explained, they should not be encouraged and told, like, no, there is no point in doing this testing. Today itself, I had one patient where they were looking for pre-testing. So this I had called her second time, and but she wanted to do insisting, but I can make out from her thing. She said, I don't want to transfer this thing to my child and all those. I said, we can help you, but now you have better choices. PGT is also available and all those things. So you need to understand this condition. You need to think what can be going into the patient's mind, the pre-symptomatic, the asymptomatic, at-risk people. So what they will be thinking. So you have to be very, very careful. So this time I insisted that you come with your husband. So that first time she came alone and she wanted to do testing. And nowadays, so many testings people are doing it, but that is not correct. Definitely not correct for Huntington. So she came this time with the husband, and he was not there, but I counseled him also over a phone call. But he also told him, like, no, there is no point. But the another thing is that you cannot deny them their right also. You are trying to make sure that you counsel them, and that point, the plus point, the advantages, and there is no benefit, that to sink in into their brain. You should counsel them at least minimum 2 times, so that you cannot deny. If the patient understand, then you can counsel them, but at the same time you have to tell them to have been in touch with the psychologist or psychiatrist, because they are the another important factors which will be there uh, throughout their lives. So post-test counseling is yeah, as I told you, like, no, is very challenging. As I already covered all those points, need to be very, very careful. If you are having affected people, it becomes very simple. But simple in the sense, it is to people who are counseling the family member, that becomes a little challenging. So the right now the treatment is very symptomatic. You give only drugs for the chorea, movement, agitation, for anxiety, and all those things. And another most important is the physical and occupational therapy, speech and swallow therapy, and making those changes in their houses. That is very important, because these people will be having so many falls. So you have to be careful that they are not getting this head injury and all those things. So though some changes, if they do in their house, that will be very helpful. Now, as I like, no, there is a recent last year only, there is a gene therapy which has come for Huntington disease, which is shown that no, you have to, by operation, you inject this, and there is a 75% decrease in the symptoms. So this is showing very promising sign. So this is already started since last year, but lot of enrollment has to happen. But it is very promising result is there. And apart from that, there are different gene silencing and RNA interference, and different future therapies are also in the pipeline. So this is one case, nothing special, but what I want to show the repeat number. So repeat number here is 44, and this is another case, nothing special, but again repeat number is 43. So over so many years, I have not seen any repeat number which is like, no, I don't remember repeat number seeing more than 50 also. So it is around 41, 42, 44. So why I am trying to say, when repeat number was not possible, so it was just a positive and negative. So we were thinking once we able to identify the repeat number, we'll be able to do lot of thing and understand Huntington much better. But as the technology advanced, we were able to get the repeat numbers, but repeat numbers are still coming around 43, 44 only. So this is one case where we have done the non-disclosure prenatal testing. So the mother's genetic testing was consistent with the Huntington, and she had a 42 CAG repeat, and there was a strong family history with the Huntington disease. So she came with the pregnancy. So we said that we can do this non-disclosure. The risk would be, without testing, would be 25%. But if you do this testing, so non-disclosure testing, sometimes it helps. So we used to do earlier CVS. So CVS may, how it happens is you test confirm the pregnancy, confirm the affected family member, you confirm the diagnosis and understand the repeat number. Then you do a CVS and you send the other parent affected asymptomatic parent sample also. If the fetus is not affected, then the parent disclosure, parents thing status will not be disclosed. But if fetus is affected, then indirectly the parent status is also getting disclosed. So those days we had these challenges with the prenatal, but now with the PGT, it is like you are able to eliminate that factor also. So counseling, late age onset challenges, disease manifestation, pre-symptomatic testing not routinely encouraged, psychological factor. Psychological factor is very important. So the to understand what they are going through is very important. Counseling is provided, and the non-disclosure testing also helps if the fetus is not affected. In this case, the fetus was not affected, so uh, the the parent didn't come to know about their status, so that helps in some time. But now, as I told you, the PGT is very helpful for all these cases. This is again very old cases when we didn't have PGT. This is no, the pedigree is not proper, but this mother had a Huntington, and it was diagnosed. She came to us. This patient came to us. We tested the mother, and mother confirmed the diagnosis, and then she was pregnant. So we did a like this prenatal non-disclosure test, but unfortunately that time the fetus was affected, and even though the daughter was not having this condition and she was asymptomatic, her status got disclosed because of the affected fetus. Now there are certain people like who are affected with the Huntington's, which is there. Thank you. If you have any questions, I can take that.
Right. Thank you so much, sir. It was a very comprehensive talk. You not only covered all the clinical, medical aspects of it, but also the very important psychological nuances and the family dynamics and those things, I think, which are actually very difficult to navigate and deal with. And again, that very a tender subject of prenatal testing and how to go about it. So
That
we have
is
some
important.
questions here, sir. Yes.
Yeah. So that
So-
is what people who have not seen Huntington and who have not seen counseling. This is what I'm saying. If you want to learn counseling, you should see Huntington patient. So there you will learn everything about pedigree and all aspects of different inheritance and the jump anticipation and what goes down. I like no. This is we early days we used to see a lot of cases. Now we see less patient because so many people and other things. But then this is always feel challenging. So that way. So if there is any question.
Oh, sir. Means, in fact, I had never thought of this aspect of survivor's guilt and that things. It's very, it must be quite challenging, sir.
I could not means I tried to, but there are different aspect of survivor guilt is there, and so many people they commit suicide because they are not able to accept the normal life. So that way, so it is very challenging. I don't know. There was Dr. Sanjeev Jain
Also,
was there.
sir, issues with insurance and other things, considering that it is a genetic condition, and then
Those days, lot of challenges were there. So we always used to say that please make sure that you insure yourself, correct your health insurances, all those things. So now you can have a genetic disease, at least theoretically. I don't know how much practical it is there. They cannot refuse the insurance. But yes, we always used to say there is no other benefit. Like except your insurance, your financial planning, and prenatal, if you're in the reproductive ages, there is no other benefit in testing you, and try to be as normal. So as today's patient also I told like no, you need to be in touch with the psychologist more so that they can understand, because Huntington, I used to sit those days 1 hour, one and a half hour with the patient, asymptomatic patient, just listening to them. So those days, not that many patient also, but yes. So that way, so it was all you learn a lot of thing with Huntington.
right, sir. So I'll just read out one question in from the Q&A box. So Pragati is asking if patient is found to be homozygous for Huntington, how to go about PGTM as all embryos will inherit the mutation.
So this is all theoretical question. So to have this is not possible, because then that means either both the parents are affected, or there is a, because you don't have a genome mutations. Okay, Huntington is not a regular autosomal dominant inheritance where you can have a genome mutation. It is the repeat number which has to expand. So that one of the parent is having pre-symptomatic, so that will not be possible. One is having strong jump, so it will be. I don't think so. It is practically. I have not come across. Maybe one of the rare thing which I have not seen.
Sir, actually, I was going to ask about that. Like, if we have like so for pre-implantation genetic testing, we need to have that patient and plus the parent from whom he or she has inherited the thing, right?
The
So
lab
if
always took as a precaution. Okay. So you
okay,
have to understand, the thing is that what we need to be sure that we are confirming the diagnosis, that we are correct,
okay,
that it is Huntington, proven in molecular level. The second, as I told you, I'm very inquisitive about repeat number now also. Okay. Early days, I was always struggling. I used to talk to Dr. Renu Saxena in Gangaram, where we used to send repeat number. Now also after coming repeat number, she always used to put plus or minus to repeat. I said, then that is so much still going wide. So
right,
that way. So repeat number is just I think clinical benefit, whether you can expect anything. But and they always take the parent sample just to be sure that you are checking that they are affected or not. But they never disclose uh, the parent status. It is
parent
only report
status.
about the fetus. So that, as I told you, non-disclosure is we used to try to help that way. But now with the PGT, this is the only thing which I feel like, I mean, today that patient, I said, we can straight away tell IVF testing is better. But obviously, there are so many cost factors and other things are there.
Right,
But it is one of the rare thing where PGT will be very helpful.
right, sir. So would it be linkage based or like
No, no,
repeat expansion?
repeat expansion only.
Repeat
If I
expansion.
remember, I have not done, but I have looked into it. There are some PGTM cocktails are there. In that,
Okay,
Huntington is also there.
okay, sir.
Huntington, thalassemia, DMD. But I don't know. I never used it. I have not done it myself. But Thermo had this cocktail. I don't know how other people are doing it. So too much technical of PGTM, we don't know. But I have seen the. But it has to be. I don't think linkage. Linkage they are doing in general. PGTM, they are doing linkage. So, but I don't think
Mhm.
there. I'm not too sure that one. Again, getting complex there. And then the linkage
Right.
means they are doing whole genome linkage, not the gene. What
And
we are asking.
the like the inherited that person is also required apparently.
Yeah,
Which I
yeah.
inquired
They are trying to get more information and no,
for
that one.
to be
So
sure for the pre-PGT workup and other things.
that amplification in the gene and DNA that gives little complication. So how
Right.
we start, we think something, and then when you actually go for practical, then you learn something else.
True. And so how far do you think are we in these disease modifying treatments like you shared in your one of your last slides that now some gene therapy is experimented like in
Means
how
it
many
gene
how
therapy.
long do you think will it take for that to come into practice?
Now I say my counseling. I say now I can say that it can happen very fast in India. Means early days when I joined, I feel like no, it will come, and India also will come. Now I'm more confident. I feel like no,
Hopeful
the
that.
we are lacking only in this clinical trials. I think, but that is also starting here. I think that gap in the clinical trial, I think will, I think slowly will narrow, and I think maybe with all this newer technology and AI and all those things, I think we should be doing much better than other people, I hope, in the clinical trial front. So that way. So now I am very confident that all those things which is happening abroad will come sooner or later to India. Not like no, you have to travel. It just few years gap. I feel that way. And but now we are able to manage also much better because of the all the support system and all those things. Not like how we used to see patient earlier and like no, we were not that much helpful. And just those days we were doing only prenatal diagnosis, only prevention. So that one now with the so much subspecialties and so much improved support system, they are managed much better. So that when so previously rare disease means we don't know. Now rare disease has become so common and people are aware about rare disease. So
Yes,
no,
sir.
now
These
definitely we are helping.
CTs and yes, sir. They are also
That
working hard to make like these difficult, I mean, the treatments more, what do you say, available to patients, like because many of these expensive treatments and other things. But things are coming to India also quite.
the only thing which if you ask me personally, difference is like no, 22 years back when we used to see patient, that time by the time they used to teach genetic department, like no, they would be completely, they won't have any hopes. Okay. And means treatment wise. So for them at that point of time, somebody understanding their condition itself was a big thing. Okay. Now the difference is now people who are having this rare disease or children with the rare disease, their expectation is like any other condition ka expectation, treatment and this thing. So that's so
They should.
that is the little difference. But otherwise, those days because they were very because everywhere they've been told there is no treatment. So by the time they used to reach
And now
genetic
with these,
that way.
I think now there is more hope with these things coming, and then they are like, how can we enroll in these treatments? And there is at least, but maybe it
It is
just
good.
gives them some thing to hold on to, that at least like if they, and with the better drugs and a wide array of drugs coming for controlling the symptoms and other things.
No, I think the conditions in India is improving, and I feel that now it will improve much more faster now as we are able to diagnose so many things. We are able to diagnose much before, and sometimes it is good, sometimes it is not good, but okay. So, but I feel treatment will be there in India, and we are doing much better means compared to early days where we were not able to help them with anything
Right.
except that to whatever limitation we can offer the prenatal diagnosis. That time prenatal diagnosis also were so much limitation that way. So I think we have quite
There is
a
another,
hopeful.
there is one more question, sir. Ria is asking, could other conditions mimic Huntington disease, and how will we rule them out?
There are different conditions are there which you can have a chorea type movement. So your assessment is very important. Your clinical assessment and all neurological assessment is important. In today's time, what happens, like as I told you, like no subspecialty is doing so great. So by the time they come to genetics, lot of thing is being evaluated. So the clinical evaluation is very important in any neurological
Yes.
condition. So, and giving time, talking to them, taking pedigree, all this thing, will give you a lot of information and diagnosis, differential diagnosis, which may not be there in other condition where you most of the time it is sporadic, isolated cases. So, but in neurological condition like Huntington and anything, you will get lot of information with your pedigree and your clinical examination. So that way. So you have to, but yes, another thing, this is different from your whole exome testing. people are left and right doing any genetic condition, whole exome testing. So that will not fit here. So that there comes your clinical acumen and the pedigree and all those things, and decide what test to be done.
Right, sir. Very important point. So I think there are no more questions. So thank you so much, Dr. Shetty, for sharing your expertise and insights with us today. And thank you everyone for joining us for this session and participating in the discussion. On behalf of ORDI, we sincerely appreciate your time and engagement. We hope this session has helped deepen the understanding of Huntington disease and many challenges surrounding its diagnosis and management. Thank you once again, and we look forward to seeing you in future sessions of ORDI Rare Info series. Good evening.
Thank you.